It's my pleasure now to introduce the last speaker, which is Professor Laurence Rocher. He will speak about testis.
Yes, thank you, dear friend, dear colleagues. It's my pleasure to be part of this webinar. And now we will focus our study, our talk on testis elastography. We will focus our talk on elastography in normal testis, in infertile patient, in intratesticular masses, and I will also share some cases in case of acute scrotum and extratesticular masses. First, elastography in adults. What are the main results? Whatever the way you perform elastography, strain elastography or shear elastography, the result is that testes are really soft. The mean stiffness with shear elastography in the middle of the testis is about 2.4 kilopascal, which correspond to 0.9 meter per second for the speed. And there are some discrepancies between the upper, the middle, or the lower pole of the testis according to Trotman and Marcon results. There are also some difference because according to the scan you use, is it with shear wave elastography with ultrafast imaging, RF, or virtual touch tissue quantification. So the result is for clinical study, you have to use the same scan, and we have to elaborate some factors in order to compare the stiffness, especially for the lesion. It's also now well known that the peripheral tissue is stiffer compared to the middle, and the hilum demonstrates also a high stiffness. Some limitation in performing elastography, and especially shear wave elastography. That's what I do the most. And you can observe some push artifacts, which are a parallel vertical hard zone, regularly spaced, and it is due to non-adapted ultrasound sequence in very soft organs. And you will see that if you use elastography in a longitudinal view, and if you see that you have to turn the probe and to perform the elastography on an axial view. Sometimes you may also observe some defects in feeling cartography, especially if there are a thickness skin, and if the testis is located inside the abdomen, the result of elastography will be probably wrong. You may also you may have to put some adjustment, and especially if they're feeling defect in the cartography. For example, for this very hard lesion, and it was really obvious with strain elastography that it was really hard, but with the standard mode, we could not observe the real stiffness of the lesion, and you have to adjust the mode, and with the penetration mode, there is no defect in the cartography, and you are able now to make the measure, but you have more push artifact in this case. What about elastography, testis elastography, and infertility? With this first study from Lee, we had hope that we could differentiate obstructive azoospermia from non-obstructive azoospermia in order to select patients which could have a biopsy. And we performed with Jean-Michel this study with about 600 patients, and despite the significant results, statistically speaking, we can see that there's really too much overlap value, and we do not perform that anymore for homogeneous testis in case of infertility. The normal value in these studies, and we performed elastography in the middle of the testis, the region of interest was located in the middle of the testis, was 2.5 kilopascal, which is the same that the Trostman study. The main topic is the characterization of intratesticular lesion, and especially for the testis. You know that percutaneous biopsy are still not allowed according to urological societies. And at the beginning, we had quite enthusiastic beginning, because in Enya, Cody's, and our studies, there were really good results. But it depends on which patients are included, and what are those benign supposed lesions. Because if you include in this result testicular cysts, which are obvious on B-mode, the results will change if only you include, of the inclusion of only a Leydig cell tumor, for example. And in this recent study from Claudia Schroeder, the real-time elastography wasn't able to differentiate benign from malignant lesion, but she only included 7 benign tumors. So I really agreed with the recommendation of the ultrasound paper. Ultrasound elastography for evaluation of focal testicular lesion can be only be recommended in conjunction with other ultrasound technique, as there is overlap between benign and malignant neoplasm. And how to do it? Well, this is example. First, if you have a lesion on heterogeneous testis, you may perform a very slow scanning with shear wave elastography, like for this example of a Leydig cell tumor. You can see this lobulation, and be careful of the scale. Jean-Michel spoke about it, and because if the scale is not adapted, you can miss the lesion. This video doesn't work. I'm sorry. This is a result, and you can see that there is an increased stiffness for this seminomatous stem cell tumor, but if the scale is non-adapted, you can see that the lesion appears not with a high stiffness, but if you measure it, it's very hard. So you have really to be careful about the scale when you perform shear wave elastography, even if the measure will not be changed. Which parameter should be used when you have a lesion with a high stiffness? And we perform with Jean-Michel this study with shear wave elastography, and we measure the mean stiffness with a circle covering quite the whole lesions. And we also put a small region of interest on the stiffest part, and also a region of interest on the normal parenchyma. On the same side, it's possible, or on the other side. And finally, in our study, the better parameter were the ratio between Emax, so the stiffest part, and the control, the E control. And we really want to say that it's in addition with the B mode and the color Doppler for characterization, because we define several findings the calcification score with macrocalcification or diffuse macroleads or group macroleads, and also a score with the vascularization. Is the lesion hypo or not vascularized? Are the vascularization more peripheral with vessels parallel to the border, or on the contrary, with a dominant central vascularization, or mixed? And finally, in addition, B-mode, vascularization score, and the stiffness, the ratio, you can have a very good area under curve. And yes, there are some overlap value. We can see on this box plot figure. And these are the table resuming our results. And you can see that malignant tumors are really stiffer compared to benign lesion, but some benign lesion may be stiffer, and we will see some example. We had also some burnout tumor, which are a rare diagnosis, and I will talk about that later. There was also a correlation between the size and the stiffness. This is an example of a burnout tumor. It's a 33-year-old man with azoospermia, and we have the surprise in discovering this hypoechoic area, not so well delimited, and it was hypovascularized both at ultrasensitive Doppler and at contrast ultrasound. And this is the video of the Strain Elastography, and you can see that there is really a nodular lesion with high stiffness inside this hypoechoic area, which matches very well with the MRI. This lesion is in hyposignal on T2. There is also abnormality on the ADC map with an increased ADC value and a defect of vascularization, and the limits overlaps the nodule on T2. So non-seminomatous germ cell tumor, they show a very high stiffness, generally speaking, contrary to benign Leydig cell tumor, but there are overlap value. This is an example of a seminomatous germ cell tumor with low stiffness and an hypervascularized benign Leydig cell tumor with a high stiffness. And for intratesticular lesions, the stiffest lesion I've ever seen is the dermoid cyst, which is benign. Another example, a recent case, this man had a back flank plane, and some masses were seen in the retroperitoneal space. And unfortunately, he underwent a surgery discovering a seminomatous germ cell tumor. And look at his testis, his right testis. It is hypoechoic, some microleads. It's not vascularized compared to the left testis. And at elastography, there is really a nodular lesion with a high stiffness, matching very well with the MRI results, like for the other example. What about acute scrotum and extratesticular disease? This is an experimental study on rats, and HEREC demonstrates that strain elastography could really have an added value in case of spermatic torsion. And the stiffness increases with the degree of torsion, but when the testis is completely necrosed, the pattern were reversed. We have not performed any study about that, but I will show you two cases. One with a small degree of torsion, and the stiffness were really the same, the right compared to the left. And for this other example, the right testis showed an increased stiffness compared to the left, where it's not showed in this figure. Orchitis may also increase the stiffness, and also the vascularization. Tuberculosis, it is a proven tuberculosis with high stiffness value. And in case of spontaneous hematoma, the compressed parenchyma may increase the stiffness. There is a rim-like pattern with increased stiffness corresponding to the compressed parenchyma. Infarction also, and it has always been shown in several studies, may also increase the stiffness. And I will show you those two cases with infarction and an increased stiffness around the infarction, and both with real-time elastography and shear wave elastography. And with this man, he had an acute pain 7 days ago, and he was referred for a tumor. But finally, you can see that the defect in vascularization, a rim-like enhancement at convolutional ultrasound without any enhancement at all at the lower part of the testis, and an increased stiffness around the necrosed part. A case from extratesticular disease. We had several cases of appendix testis torsion demonstrating very clearly an increased stiffness, and it may be an added value for this tricky diagnosis. Epididymal tuberculosis also, there was no so much vascularization compared to classic epididymitis, like in this case, but it is very hard on elastography. Some adenomatoid tumor may also have an increased stiffness, and it may sometimes it is not so easy to depict them both on B mode, color Doppler, and even with MRI, and it is so obvious in this case. This is a little lesion, which have been discovered by self-palpation. This patient had an infertility screening, discovering a benign Leydig cell tumor with a slight stiff lesion, and the elastogram demonstrates also, and we have not seen that at the B mode, but afterwards we saw that there was a real increased lesion at the periphery of the testis, corresponding to an adenomatoid tumors. Lipoma are soft, and we can see that very well with this extratesticular fatty lesion, well seen at MRI, but also on B mode, and the stiffness of the lesion was at 3.8 kilopascal. And the last case, it is an 18-year-old man. He palpated himself a mass of the spermatic cord, and it is the stiffest extratesticular lesion I have ever seen, about 200 kilopascal. And we assessed the diagnosis of fibrous pseudo tumor, and the patient had surgery with preservation of the spermatic cord. So to conclude, well, testes are solved. In case of infertility, there's too much overlap value, helping us to differentiate azoospermia, obstructive azoospermia from non-obstructive azoospermia. We need more study dealing with the characterization, but it still seems promising. We continue our study, but the fact that there are overlap value do not prevent us to perform it. I think it's better to choose quantitative elastography if you have the choice. It's help in detecting and characterizing burnout tumor. Keep in mind that non-tumoral disease may increase of stiffness, and we have to get used to several manufacturers and techniques. Thank you very much for attention.
Thank you very much for your presentation. I think it was very clear and with really nice images. There are no questions for now, so thank you very much one more time. I want to thank everybody for participating, and before finishing this, I think all the participants received a link for the quiz, for the Elasto small parts quiz. And basically, when you follow up the link, you can complete the quiz and you'll receive your CME credits by email. So please be careful to complete your email address. Before finishing, I want to thank all the panelists for their presentations. And I want to kindly invite you in April for the second part of the elastography non-liver guidelines, including pancreas and GI tract lesions and also spleen. So thank you very much one more time. I don't know if Vito or Professor Anachescu want to say something, or Professor Cantisani, I don't know. There are no more questions, I think.
It is a pleasure. And this was an initiative that we started some years ago. It's very nice that it's successful. I thank Adrian for your great work to share our session, all the other speakers, and everybody who is attending our webinar. And I wish you a good night. Bye. Ciao.
Okay.
Bye-bye.
Thank you very much, Professor Cantisani.
Thank you. Bye-bye.
Okay.
Bye.
Thank you very much. Have a nice evening. Bye-bye.
Bye-bye.